The views and opinions expressed on this program do not necessarily reflect or represent the views and opinions of 580 WCHS or West Virginia Radio Corporation.
We're going to have a great discussion focusing on OBGYN issues with adolescents. And first of all, let me set information out. WVU physicians can be found online. It's WVUPC.com, WVUPC.com. And also, Dr. Montgomery, if you want to talk to her office after you hear our show this morning, you can get a hold of her at 304-388-1515. Is that right? Did I write that down right?
That's right.
Okay, good. Sometimes my writing is questionable. So that's 304-388-1515. She's located over at the WVU Physicians OBGYN office, which is at Women's and Children's Hospital right here in downtown Charleston. First of all, let's just talk about you just for a minute so folks can get an idea of who you are a little bit. Are you originally from this area?
I am. I grew up in Ripley, graduated from Ripley High School way too long ago. And then I went to West Virginia Wesleyan College undergrad and WVU for medical school.
Well, we like keeping our doctors local, so thank you for staying in the state. That's for darn sure. And so you work here in Charleston now. How long have you been in practice?
Well, that's kind of a convoluted story. I actually was a family medicine doctor for about 9 years and then decided I really loved OB, so I went back and did additional training, and I've been practicing OBGYN for about 8 years now. Okay, all right.
So what I find interesting about a little discussion that we had before we went on the air this morning is that you actually focus on adolescent OBGYN issues, and that's something that there's actually not a lot of OBs that practice that in the state or that focus on that?
Correct. So I do all OBGYN from, birth to womb to tomb, basically. But I do have a special interest in adolescent gynecology and recently was certified to practice that specific area. And I'm the only one in Charleston who has that certification. So that's an area of my interest that I want to try to, take to the people and let them know that there is access to somebody who has that special interest and special training to do.
So when you talk about the certification, does that mean that you're a doctor anyway, but you can do continuing education that focuses on the adolescent portion of that, and that's where that comes from?
Well, I did do continuing education in that, and then I took a test that was sponsored by the American College of Obstetrics and Gynecology, and that's where I got the certification, was from that.
Outstanding. I find that this is all is going to be important information that we're going to share, because if there's one thing that I've noticed over time in medical fields and stuff like that is you have a lot of overlap with different fields and different areas of expertise, but sometimes there is that sliver that kind of falls through the crack a little bit that causes a little bit of an issue. And so this is one of those situations. I guess I need to ask you, you found it within your passion, within your calling to focus on adolescent OBGYN. What kind of led you to that decision?
Well, I'm a mom of 3. I love kids, and pediatricians have so much to do with well baby checks and the normal stuff that pediatricians do that they really don't have enough time to get the training or have the facility even in their office to take care of the GYN issues. On the other hand, gynecologists are much more focused on adult medicine and taking care of their OB patients. And so they are uncomfortable sometimes taking care of kids. The exam is different. The way you approach the patient is different. And so their office really geared toward adults, and it's hard for them to transition into children. So there really is a gap in care for those patients. And I've heard throughout my career from my pediatric colleagues, like, we don't have a place to send our patients. And so it was an interest, and I knew it was a need, and so that's why I pursued that, so that we could have that here in the area to take care of the people who need it.
That's really fantastic. If you're listening this morning, if you are an adolescent that has questions, and obviously if you're a parent or a grandparent of one, a caretaker in some other way, or if you just have a question that pops into your head, you can give us a call this morning. Our number is 304-345-5858, 304-345-5858. If you hear a portion of this program and you want to go back and listen to the whole thing, I do want to remind you that all of our podcasts are published within about an hour or so after they leave the airways. You can go to WCHSnetwork.com, and you can see the podcast link right there on the front page, or you can go to WCHS wchsnetwork.com/podcasts, and that'll take you directly to the podcast directory. Also, I want to remind you, if you go to our site now, or if you go to your app store on Google Play or on Apple, you can just search for 580 WCHS. We now have our own dedicated app, so if you want to listen to Ask the Expert from anywhere in your car, your office, your home, or anything along those lines, you can do so on our dedicated app. And so, Dr. Montgomery, I guess one of the first questions I have to ask you this morning that's pursuant to your field is the differences between treating adults and adolescents. What are some of the things, first of all, when you talk about focusing on adolescent issues, at what age is that, or do they age right into you? Like as soon as they start to go see OBs, should they start to see you right away? Or is it if the other issues develop in some way? So
in general, I think adolescents or women should start seeing a gynecologist at 18.
Okay.
We don't do pap smears until age 21, but there are other issues that can come up before then. Now, my personal experience is that, you know, a lot of our patients are seeing or being sexually active before they turn 18. Mm-hmm. And I think they should be seen at least once a year once they become sexually active. I also, you know, my practice is open to pediatric patients, little girls, because they have issues too. Sometimes they have infections or growth or even premature puberty, things that can come up even in, you know, 2 or 3, 4-year-olds. So my practice is open to all of those patients.
And that answers kind of what my next question was going to be. I view everything through the prism of having a newborn now. And so with a 7-month-old, I was kind of wondering, although she's 18 years away from being an adult and hopefully away from being sexually active, at the same time, other issues can come up. Even being a new dad right now, other issues come up where I have to call my wife and I'm like, hey, honey, is this all right? What do we need to do? Because I don't know, you know.
Right.
So it is nice to have that resource, especially once you get into, like you said, 3, 4, 5 years old. If something's going on that's a little bit abnormal, or if you're not sure, at least there's a resource that you can go to for someone that specializes in those things, is up on the most updated information, knows all the best practices, so on and so forth. I mean, that gives you a little bit of confidence in the decision that you're making.
Yeah. Now, a lot of the pediatricians can take care of the routine stuff, you know, so that would be my first stop still. But the next stop, you know, when it's specifically a GYN issue.
So let's talk a little bit about some of the things that's commonly you see. First of all, let's get to the elephant out of the room a little bit. You did mention about once you become sexually active, you should go see an OB. A lot of people, of course, when you talk about young daughters or something out there, may not share with their parents if they're in their mid-teens or something along those lines. You know, we do the best that we can, but things happen sometimes along those lines. Do you encourage an open dialogue between parents and children in that case then, so that the child can be seen without there being as much conflict as possible?
Yeah, I try to. You know, in West Virginia, I mean, obviously there's HIPAA laws,
right,
and there's some specifics, I guess, caveats for GYN where I can see and take care of an adolescent without parental permission.
Really? No, I wasn't aware of that.
I can provide birth control and take care of a lot of those issues without parental, which becomes an area of conflict because obviously moms and dads want to be involved, but I legally can't do that. The child can access me without. Now, insurance is a different issue, you know.
Right, but if they're paying, if they have the cash to come to you and to pay, and they want to become your patient at 15 or 16 years old, they can.
Right, and I tell them, and usually I try to tell them in front of their mother, because that's usually the parent who brings them, that she and I now have a special relationship. The patient and I do, and that unless she gives me permission, I can't share anything that she tells me with her mother or father. And so, you know, if there's a major issue, let's say there's an infection or a pregnancy or whatever, I encourage, you know, can we please bring mom in? Can we include her in this conversation? She needs to be a part of your support system. But legally, I can't do that until the child gives me permission to.
And honestly, as much as even as a parent, I'm like, you know, but when it comes to the health and the safety of our children, sometimes you just can't make that connection. Sometimes, you know, you make a mistake. You don't really want to share it with your folks. You're trying to take personal responsibility for it. I mean, you hate to go down that route, but at least if they're taking that much responsibility to seek out a doctor, at least that shows that there's some forward thinking on that person's part, where maybe they're thinking, okay, well, at least I need to be responsible for myself if this is what's happening.
Right, and that's kind of the philosophy behind this, you know, privacy kind of thing, is that we want we don't want to do anything to discourage girls from getting care. If they know as soon as I find out I'm going to call mom, they may not be honest with me and tell me what's really going on. A lot of times mom is there in the lobby or whatever, and she'll admit to me that she's sexually active or that she's been exposed to an infection or whatever. And she would not necessarily tell me those things if she knew that I was going to share it with her mother.
Yeah, that makes a lot of sense. And anything that provides the best health care really is what you have to look for. And you do it within the best of your ability to bring folks in. But at the same time, you want to make sure you're treating folks and you're getting them, because the last thing you want is for somebody to be suffering from an infection or some other issue and be scared to seek out help. And then other issues arrive, or even, mortality in some way. You don't want that to happen.
Absolutely.
And so that's really the bottom line. Speaking this morning already with a great discussion, Dr. Elizabeth Montgomery. She's from WVU Physicians of Charleston, located at the WVU Physicians OBGYN building over Women's and Children's. More information online, WVUPC.com, WVUPC.com. Her phone number is 304-388-1515 if you're looking to follow up or make an appointment, or if you have any questions. Dr. Montgomery does focus on adolescent OBGYN issues, although she does practice the whole range. So if you have any questions this morning, you can give us a call in real time right here on the radio. You're also welcome to use an alias if you want to. I know sometimes when we talk about medicine and finances, a lot of times people don't want to use their real name. Completely fine. You can use an alias if you want to when you call in. If you have any questions for Dr. Montgomery, our number is 304-345-5858, 304-345-5858. So let's talk about some of the issues that come up with adolescents, and maybe things that parents aren't aware of. And I'll use this to selfishly mine some information for down the road for myself. What are some things, if you're the parent of a teen, that you run into sometimes, maybe that's even region specific in some way, either diseases, disorders, any type of problem that you run into that seems to be, that happens to adolescents in our area a lot?
So probably one of the first things is that for the first 2 to 3 years of the girl's menstrual life, periods can be very irregular. May not have a period but every 2 to 3 months. They may be very heavy. They may, and that's normal. I have a lot of patients come in because they're worried about irregular periods, but they've only been menstruating for a year, and so that's completely normal. You can regulate it with birth control pills if it's a big enough issue. It's interfering with sports or keeping you home from school or whatever. But in general, if you just wait, it'll normalize, it'll regulate on its own. So that's the first kind of big thing that comes up in adolescence. And of course then there's the issues of, if you do start hormonal treatment, what are you going to do? And if you want to just regulate your cycles, pills are probably the best option. But my preference, and most of the organizations who make recommendations like this, is if you're going to be giving a girl contraception, not cycle regulation now, but contraception, one of the long-acting reversible contraceptives like an IUD, or there's a rod that can be implanted in the upper arm, and both of those provide excellent contraception, much, much better than the pills do, and they're safer. They're a lot safer than pills as far as the medical complications that can come from that. The reason why I think we need to start seeing girls at when they become sexually active is that girls can have infections, particularly chlamydia, but also gonorrhea, without symptoms. So I screen all of my sexually active adolescents at least once a year for those two, and I would say at least every couple months I find a girl who had no symptoms, had no clue that she was infected. But she was carrying chlamydia, and of course that she can pass it to other people. But worse than that, for her at least, is that if you have a chlamydial infection that's not in treatment, not treated, it can cause infertility in the future. So it's something we need to take care of, real time.
Yeah, that's something that. So in that case, with something like chlamydia, does that mean that your partner also doesn't show the symptoms of it, generally speaking, when you contract?
Either he doesn't have them or he doesn't want to admit that he has them.
Okay, yeah, well, that I guess that makes a lot of sense. And so a lot of what you're doing is trying to get to early diagnosis and screening and things along those lines, especially for these diseases that you can have. And when you're asymptomatic, I mean, you would really have no other way to know unless you have a regular checkup. Can you speak for a moment the importance of regular checkups? I know that sometimes women get used to this at a much earlier age, I think, where you have to go to the doctor and get your regular checkups. But I also know that there are guys out there that skip their yearly appointments or whatever it is. There are women out there that do the same thing. They don't want to have their pap smear this year or whatever it might be. Speak a little bit to the importance of why a regular appointment, based on your doctor's recommendation, is important for the health of a woman and an adolescent specifically.
So, the annual exam, of course, is to find disease, as you said, before it's a problem, really, and the pap smear is to find cervical changes that may eventually turn into cancer, but are completely asymptomatic up until then. Now, things have changed a little bit with pap smears, and that's something that I'm still educating all my patients about. And the guidelines now say we don't start paps until 21. And if your pap is normal, you only need one every 3 years. Until age 30, and then at 30 we can add an additional test, and if both tests are normal, you can actually spread your paps out to every 5 years. But remember, pap is only to screen for cervical cancer. At your annual exam, we also do breast exams to screen for breast cancer. We do a pelvic exam to feel the uterus and ovaries to make sure that they're not enlarged and may have a problem there. And we do a lot of history, what's going on with you, and sometimes I found thyroid cancer, I found, circulation problems. Woman feet were blue and it was just normal for her. And like, we need to fix this.
Yeah.
So there are other things that we can find on the annual exam that can make your life better if we can get you into treatment.
304-345-5858, 304-345-5858. If you have any questions for Dr. Elizabeth, I almost did it. Dr. Emily Montgomery. Oh, my goodness. Dr. Emily Montgomery from WVU Physicians of Charleston, located over at the WVU Physicians OBGYN building at Women's and Children's Hospital. So I find that this discussion in trying to unearth little nuggets, I wish that I had more. I mean, obviously, as a guy, a lot of these innate questions that I wish I had, and I did a little research trying to come up with some things this morning. It's such an important thing. In West Virginia, we have a lot of environmental issues that come up. My wife, for example, suffers from endometriosis and PCOS that probably could have been diagnosed at an earlier age and helped her out a lot more. Is that something that you run into as well? And is that something that if caught earlier, and at what age is that something that you can actually diagnose and catch?
So you brought up two issues. First of all, PCOS is extraordinarily common in West Virginia and probably in all of Appalachia. And part of that is we have an increased obesity rate, we have increased diabetes in the area, and all those things kind of go in together and are part of the PCOS metabolic syndrome. So PCOS is when you don't ovulate. Like every month, a woman's supposed to have a cyst that gets bigger and bigger, which is another really important point. Cysts are normal. People get really nervous about cysts, but cysts are normal. Once a month, you get generally one cyst that gets to be about 3 or 4 centimeters, and then it breaks open. The egg is inside that cyst. It pops out, and then you get pregnant or you don't get pregnant. With folks with PCOS, they never have that one single cyst develop. They have a bunch of little tiny cysts that never develop enough to release an egg and grow up to be somebody. So they don't ovulate, therefore they have irregular periods. They can go 3, 6, 9 months. I've had patients go a couple years without periods because it's the ovulation that triggers the next period. And if you don't ovulate, you don't have a period. So other things that go with the syndrome, obviously syndrome implies that there are other things that go with it. So obesity is part of that. Testosterone excess is also part of it. So a lot of these women will have hair on their face, on their lower belly, on their inner thighs, areas that we think of being more typically male pattern hirsutism. And so combination of anovulatory cycles, not releasing an egg, and extra hair, and generally obesity too, and there's some specific findings on ultrasound. All those things go together to be PCOS. And there are a whole lot of issues related to PCOS. There's obviously fertility, as I spoke about, but there's also increased risk for uterine cancer down the road. And there's the metabolic stuff like hyperlipidemia, high cholesterol, high blood pressure, diabetes, all these things that become much bigger issues later in life. So when I start with an adolescent who has PCOS, there are a couple issues we need to take care of. Regulating her cycles, preparing her for fertility treatment in the future potentially, but also encouraging her to lose weight and exercise so that she delays these other metabolic problems that may develop when she's 30, 40, 50 years old.
Before we might move on to endometriosis, and we'll take a break too, just to share a little bit of a personal background. I mentioned that my wife had suffered from PCOS. It was undiagnosed in her. She's 35 now. She was 34 when it was finally officially diagnosed in her, which is very odd because we had been undergoing fertility treatments for about 6 years by that point. And it wasn't until we changed doctors and the new doctor in the middle of our IVF cycle that we had finally funded and were in the middle of, just kind of said, "Hey, you know what? You definitely within moments of looking at her X-ray and getting everything up, was able to notice that she had PCOS, and noticed right away that he had some other procedures, some other ideas on how to try to mitigate some of the body's responses to that to help her get pregnant. The IVF worked on the first try. However that relates, it's impossible to tell, but I can't help but to wonder, after 6 failed IUIs and then finally having to go to an IVF to get my wonderful little daughter, what would have happened if she was diagnosed with that earlier? You know, maybe if she went to go see an adolescent OBGYN when she was younger, if she had the symptoms then, and maybe this was something that had been treated all along, it may not have affected her down the road. I mean, we have no way to tell, but she was furious, I guess would be the right word, because she had actually asked her previous care provider in fertility, "Is there any signs of PCOS? I know that I'm a high risk for it, et cetera," and was told, "No, we haven't noticed anything like that." And our new doctor literally noticed it within moments of looking at her first screen. So that's just one of those things that you wonder if it was diagnosed a little bit earlier on, if maybe, I mean, I hate to say it from a purely selfish standpoint, but thousands of dollars later, maybe it's something that wouldn't have needed to happen.
Yeah. I think obviously your experience is different, but most gynecologists, even general gynecologists, not adolescent, are very aware how common that is in West Virginia. Yeah, right. It's a big problem.
You would think that that's something that would catch, but it just goes to, it's just one of those things though. And when we do medical shows on Ask the Expert, it's always kind of the same thing. Early detection is the best, you know. So if it's something where you're dealing with an adolescent issue, seeing someone who's an adolescent-focused OBGYN is going to help you in a lot of those situations, because the earlier that you can start getting treatment and getting something recognized, the better it's going to be for you in the long run.
Absolutely.
Is that right? Yeah. With me this morning is Dr. Emily Montgomery. She is from the WVU Physicians of Charleston at the OBGYN building at Women's and Children's Hospital. You can call us this morning at 304-345-5858, 304-345-5858. Also, office number for Dr. Montgomery is 304-388-1515. That's 388-1515. More information, as always, at WVUPC.com. We're going to take a break, and we'll be back right after this on Ask the Expert. You're listening to Ask the Expert with WVU Physicians on 580 WCHS, the voice of Charleston.
Happy New Year from Gene and Ryan at Walker Chevrolet in Nitro. The new year is the best time for a new car, but a car doesn't have to be brand new to be a new car. After all, if you haven't owned it before, then a used car is a new car to you.
Yes, that's correct.
Here's the key. A factory new car is just like any other, but used cars are one of a kind. So you need to shop the best selection, and nobody's taking a backseat to Walker Chevrolet when it comes to selection. That huge lot next to the Interstate Bridge is packed with cars and trucks and every kind of vehicle. There's 4x4s and crew cabs and front-wheel drives to beat the West Virginia winter roads. And best of all, those cars are selected by Walker Chevrolet. Yes, Gene and Ryan look them over, and they keep the best ones for you. The clunkers go to the auction. Gene and Ryan want to make friends, and the best way to make friends is to sell good cars for good deals and treat people right. Start off the new year with a new or used car that's new to you at Walker Chevrolet in Nitro, where Gene and Ryan are making friends, one deal at a time.
Good morning. Watch for traffic congestion on I-64 westbound, mile marker 45 at the Nitro Bridge, and a winter weather advisory is in effect until 10 p.m. tonight. 1 to 2 inches of snow possible, with higher impact along I-79 and I-64. Expect snow-covered roads and limited visibility in some places, and use caution while driving. Traffic brought to you by City National Bank, where you can purchase or refinance your home with a no-down payment mortgage. City National Bank, equal housing lender. For a convenient location near you, log on to bank@city.com. This is Jeannie Kay on the Voice of Charleston, 96.5 FM and 580 AM, WCHS.
You're listening to Ask the Expert, WCHS, the voice of Charleston. I'm Dale Cooper. Thank you so much for tuning in on this Wednesday morning. With me in studio this morning here at 580 WCHS at 1111 Virginia Street, the audio center of the universe. Dr. Emily Montgomery is here. She is from the WVU Physicians of Charleston, located at the WVU Physicians OBGYN building at Women's and Children's Hospital. Her phone number is 304-388-1515, 388-1515. More information online, WVUPC.com, WVUPC.com. You can call us this morning if you have any questions. And I know that medical issues sometimes is a little dicey to go on the radio. You're welcome to use an alias if you want to. We won't try to out you or anything else, but if you have a question that's burning on your mind, it's not often you have the opportunity just to talk to a doctor, not in an environment appointment setting. Not that Dr. Montgomery can give you a diagnosis on the radio, but she can at least point you in the right direction for those things. So if you want to give us a call, anything that has to do with OBGYN issues, you're welcome to call about. If it happens to be something that's adolescent focused, that just happens to be Dr. Montgomery's specialty. So if you're an adolescent, or if you have a child or a grandchild or something that's having some issues and you're wondering the best direction to be pointed in, then you might want to give us a call this morning. Our number is 304-345-5858, 345-5858. We talked about PCOS a little bit just before the break. Something that you mentioned is very common for women in Appalachia. Moving over to endometriosis, which is the other thing I mentioned, something else that in this area, for whatever reason, now my wife claims that everybody in Nitro has it. She just says, if you grew up in Nitro, you have endometriosis. I don't know if that's true or not. I don't know if there's any way to really prove that. But I think the point is that it's also something that's fairly common in this area.
It is. And like PCOS, it's a little bit difficult to diagnose. I mean, you can certainly get a history from a patient that is consistent with and makes you very suspicious that she has endometriosis. But the only way to definitively diagnose endometriosis is actually surgery. You have to go in and look and see if you can find the lesions, that are represented endometriosis. Now, let me tell you what endometriosis is, because that's a little confusing. So the endometrium is the lining of the uterus. The uterus is mostly made of muscle, but inside the uterus is a lining of glandular cells, and that's what gets thick every month and prepares for a pregnancy, and then is sloughed off when the menses occurs. And most of that is supposed to come, or all of it, I guess, is supposed to come out. But for some reason, some of these glands escape the uterus and end up out in the abdomen. There are several theories about how that happens, and we really don't know exactly how those glands get out there. But we do know once they're there, they respond to the hormones just like the lining of the uterus does. So every month when the lining of the uterus gets thickened, these areas that are out on the abdomen where they're not supposed to be, out in the belly, they grow. And then when the uterine lining sloughs, these areas also bleed. And blood can be is very, very irritating to the abdomen and to the pelvis. And so that's where a lot of that pain comes from, is they're bleeding into their abdomen. And then scar tissue can form. And the longer the endometriosis goes, the more scarring happens. And the lining of all the internal organs are covered by a really slick kind of... it's not skin, but it's a tissue. And so the organs are supposed to slide easily around each other. So as you move, they don't get tugged or pulled on. They just move with you. But once this scarring occurs, then these organs are kind of locked in place. And then as you move or have bowel movements or more periods, you have more and more pain as time goes by. And so as you said earlier, if we can get people into treatment earlier, and prevent that scarring from happening and decrease the amount of implants or these little endometrial seeding that happens into the abdomen, then we can help them with their long-term symptomology.
Wow. It's amazing to me that sometimes, and unfortunately, I think that a lot of times that, I think you mentioned that it's hard to diagnose sometimes. I think that there's a lot of young ladies out there that go through this and suffer through it through high school years and into their young adulthood and until you get diagnosed and start getting treated. But by that point, you might already have some issues that, although you can get relief and it get better, but it may never be able to be as relieved or as better as it could if you diagnosed it at an earlier age. So
right.
Really, again, early detection, adolescent or not. What is about the age that starts to develop? What would you say would be, maybe this is something we could look into?
Late teens, early 20s is usually where, most women have some cramping during their cycle, and that's just the uterus trying to squeeze the tissue out. But when it becomes more extreme, or if your periods start getting really heavy or really significantly painful, that's when we need to start looking at it. Now, thankfully, the treatment, the initial treatment, is what we give most girls, birth control pills and Motrin. That's the initial treatment, and that sometimes is all they need. But sometimes we have to escalate all the way up to giving the medicines that essentially put them into menopause and shut the hormones down. And in extreme cases, we actually have to remove the pelvic organs, take out their uterus and their ovaries, so that they have time to, they no longer have that hormonal stimulus to make them bleed.
Very interesting. So again, if you're out there, if you're listening to this and have suffered from this, if maybe your daughter or granddaughter, you hear something about, maybe unusually uncomfortable menstrual cycles, something along those lines, and maybe they're a late teen or in their early 20s, point them in the right direction. Maybe for some reason they haven't seen a doctor for a while, or they avoid the doctor, whatever it might be. Point them in the right direction, because getting this diagnosed early and getting it treated and having that ongoing treatment really could benefit just long-term quality of life. I mean, it could really make things a lot better. I know that my wife to this day suffers from painful and very heavy periods, and a lot of that has to do, I think, with the endometriosis. She's had to have 2 or 3 surgeries, I think, where they, I don't know what happens. I guess you go in and you clean up some of the scar tissue or something along those lines, which will give her temporary relief, but eventually it always builds back up and it always gets bad again. And it's just a bear to deal with as an adult. It's something you have to deal with a lot of the time, and it just complicates issues on top of all the other issues that have to go on. I thought one of the things that we could talk about just in the last couple minutes of the program, since you do deal with adolescents, we talked a little bit about early sexual activity and things along those lines, but you also deal with ladies through life and pregnancies through life and things along those lines. So more from a general perspective, when we talk about infant health and mother health and things along those lines, in West Virginia, when you look at some of the bad practices, some of the bad habits that some of our prospective mothers are into, what's the number one thing that you would tell your patients or people that's just listening to this program as either a prospective mother or someone who's currently pregnant? Don't do that.
Well, I think the obvious answer is the opiate problem that we have now. I was telling someone earlier this morning, it was just within the last few weeks that we have 18 babies in our nursery whose parents had already gone home. The kids had to stay, and of the 18, 13 of them were addicted. The others had some medical problems, but that's a huge majority of our babies who are having to be withdrawn from their medicines because they became addicted while they were in their mom's bellies. Now, one of the issues there is some women are under the, I think, misinformed in that they think that their babies can't get addicted inside, and that their babies would be harmed from them withdrawing or them, weaning down while they're pregnant. And that was an old theory that, you shouldn't wean during pregnancy because it hurt the baby. If you go through withdrawal while you're pregnant, that could hurt the baby. But a slow weaning program is actually a really good thing. And actually, Dr. Calhoun, who's one of my colleagues, has a whole program at Women and Children's to try to get pregnant women weaned down off their medicines before the baby's born, so the baby doesn't have to stay in the hospital for weeks on end. But smoking is also really bad. I mean, all the substances that we take into our bodies, alcohol, tobacco, opioids, all of those things can cause long-term problems for the pregnancy, for the mama, but also for the baby.
One of the I guess depressing things as we were going through after my wife did get pregnant and we would go for the follow-up visits and so on and so forth. One of the depressing things that you would see occasionally is a pregnant lady standing outside at the hospital smoking a cigarette. And I got to tell you, it makes me a little mad.
Sure.
It really does. That's not that baby's choice. I mean, the mother can do whatever she wants to. Obviously, it's a free country. But once you take responsibility for that child that's inside you, and that just seems like the wrong thing to do. And when you see, and I've been before waiting for traffic to clear or doing something where I've been waiting for my wife who's in an appointment or something like that, and just see somebody cigarette after cigarette, smoke one, throw it away on their phone outside of the doctor's office, smoke another one, throw it away, and here's the baby bump, and I'm like, oh my goodness,
Right.
What are you doing? It really makes me sad.
And not only can it harm the baby, like the low birth weight and those kind of things, but you can actually lose your baby over those kind of things. You can cause an abruption or other things, premature labor, things that can cause the baby to die. You know, I mean, it's a bad thing.
And as far as the opioid thing goes, I've read recently about some devices that are trying to make it a little easier for babies to come down who are addicted from the mother, like the bridge, I think is what one of them is called, something that helps dampen the neurological responses to addiction. But at the same time, I watched the documentary not that long ago, and it literally made me cry to see what newborns who are born with addiction and have to come off of that with withdrawal have to go through, the pain and the discomfort, and how obviously that they're in distress when this is happening. It's something that makes me don't do this, mothers. I mean, I know that it's easy to say, me behind a mic and you suffering through addiction or whatever it is. Seek help. Get into one of these programs.
Right.
And for mothers that might be worried about law enforcement or prosecution or something like that, if you seek out a doctor to help you get off these programs, the doctor's not going to turn around and turn you over to the police.
Absolutely not. That's not going to be an issue. And Child Protective Services won't be involved if you're coming prenatally. Now, once the baby's born, that's a different issue.
Right. And I think that's a distinction that folks need to realize, that if you're trying to make yourself right to birth the baby, you're in good shape as far as the doctors, law enforcement, things like that goes. If it's afterwards and you're still having problems, that's a whole different, and rightly a whole different story, because you want to make sure that things are going well on that end. Just a couple minutes left in the program this morning. Dr. Emily Montgomery has been my guest. Just a fantastic discussion this morning on women's health issues, especially focusing on adolescents. You can find out more information online at WVUPC.com. Dr. Montgomery is located over at the WVU Physicians of Charleston OBGYN building that's at Women's and Children's Hospital. You can call her at 304-388-1515, 304-388-1515. I understand that some of these issues are a little sensitive to talk about on the radio. It's okay if you didn't call this morning, but write down that number and you can call right now. You can call, or you can call a little bit later on. 304-388-1515 is the number that you're going to call. Just with a couple minutes left in the program, and to kind of summarize what it is that you do and advice that you would give parents of adolescents out there. As far as that goes, you said that not sexually active, a child at about 18 is when they start seeing an OBGYN, right?
Right.
And then in that case, that's not necessarily one, although you're open for patients, that's not where you would say necessarily that your adolescence focus would have to be part of the routine there, just as somebody's 18 and not suffering any other complications. However, if you have adolescent specific problems or something along those lines, or if you just want to have Dr. Montgomery as your doctor, which is completely fine, that's a good reason to call you.
Absolutely. I will welcome all new patients of any age.
Of any age. I think that's the important thing. You said you saw someone who was 71 just the other day, right?
Yes, I did. I see, like I said at the beginning, womb to tomb, everything from birth on. And
just stay healthy out there. And if it's something that you're very much a part of, as far as your health and your well-being and the ways that you can address those things, it's just important to for the early diagnosis, to get early treatment, to go in and see your doctor. And that's one of the reasons that we're doing this program, is to make these things aware to you, so you can take the appropriate steps. So once again, you can get a hold of Dr. Montgomery. Her phone number is 304-388-1515, 304-388-1515, located at the WVU Physicians building at Women's and Children's Hospital. And you can give her a call, once again, 388-1515. You've been listening to Ask the Expert this morning. Dr. Montgomery, thank you so much for your time. I learned a lot. I hope the listeners did as well.
Well, thanks for having me. I had a good time.
Maybe we'll follow up again sometime soon and have you back.
Anytime.
Thank you so much. That's Dr. Emily Montgomery from WVU's Physicians of Charleston. Coming up next, I'm going to walk across the building and fill in for Mayor Danny Jones. You'll hear me in just a moment. You're listening to 580 WCHS, the voice of Charleston. I'm Dale Cooper. See you on the other side.
580 WCHS-AM, 96.5 FM Charleston, and 104.5 FM Cross Lanes, a West Virginia. 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 Cross Lanes.